So we are just discussing again on the topic of ophthalmology, which is related to MRCP questionnaire. There are some high yield topics we have discussed last week rather. We'll relook in the topics, and whatever we have missed, we'll discuss again. Okay. So what we missed is some of the syndromes like Sturge-Weber syndrome, which usually the patient have some neurocutaneous disorders, some nevus on the face, which can be there since birth, along with some features like some amount of patient presenting with seizures and eye symptoms. So skin symptoms, seizure symptoms from the neurological side, and some amount of ophthalmological features will be in the questionnaire as a clue to diagnose as Sturge-Weber syndrome. So three main features in the imaging, they may give exactly hallmark features of CT scan, tram tract cortical calcification signs. Neurologically, their patient may present with a stroke or seizure. Along with that, the features of skin nevus like wine colored skin patches will be there, and there will be some amount of ophthalmological features will be there like eye involvement. So features will be like glaucoma, visual field defects. There may be enlarged eyeballs like ophthalmos, and maybe some choroidal hemangiomas in the ophthalmology part of the questionnaire. But along with there will be symptoms of seizures or maybe signs of port wine stain in the skin as a clue, so that you can diagnose as Sturge-Weber syndrome. The evaluation will be from the history and clinical examinations, and very pathognomonic CT features of tram tract sign may be given in the questionnaire also, and EEG also can be given in the features as a features of seizures. So all these neurocutaneous syndromes along with ophthalmological findings in the fundoscopy or visual field testing will be given in the questionnaire to diagnose as Sturge-Weber syndrome. Other than that, some multi-system disorders like neurofibromatosis type 1 also can present with some ophthalmological and other neurological symptoms, like in the leash nodule in the iris, which is defined as small benign pigmented iris hematomas, along with features of neurofibromatosis can be there. So if the question defines about the leash nodules in the ophthalmoscopy, the diagnosis will be neurofibromatosis type 1. Of course, there will be features like the age of the onset, other clinical features of neurofibromatosis like optic pathway glioma. All these clinical features may be given in the question. So leash nodules, optic pathway glioma goes in favor of neurofibromatosis, and skin nevus, seizure, and other features of ophthalmologic visual field defect, seizure, goes in favor of Sturge-Weber syndrome. So other than that, we'll discuss the most high yield topics in ophthalmology in MRCP we have discussed last time, especially come with the vascular emergencies. So if the features is suggestive of atherosclerotic disease in a patient, elderly, diabetic, hypertensive, sudden loss of vision, which is painless, and the ophthalmology feature shows pale opaque retina, that means the reduced blood supply to the part of the retina, sudden onset, painless loss of vision. Pathognomonic ophthalmological features is narrowed blood vessels, cherry red spot, and pale retina, goes in favor of central retinal artery occlusion. So it's an arterial occlusion that is a pale retina in a vasculopathy patient who is elderly, maybe diabetic, hypertensive. Most important, sudden visual loss, painless, with ophthalmological features which are very pathognomonic. So how to diagnose? Because it's a emergency, you have to differentiate it from the inflammations or infective causes, and also from the central venous occlusion, which will be a different ophthalmological features. So if it is inflammatory, you may give steroid. If it's a cardiovascular disorder, you have to stroke, you have to think about intra-arterial thrombolysis also. But ultimately, as a physician, especially in NHS scenario, you have to refer to a ophthalmologist for a ophthalmic emergency. Similarly, the central retinal venous occlusion, of course, it will be again a sudden painless loss of vision in a vasculopath. There will be no headache, photophobia, flashes or floaters, which is usually features of different vitreal disorders. And in fundoscopy, typical hallmark is stormy sunset, because there will be multiple hemorrhages, tortuous veins, cotton wool spots, and disc swelling, optic disc swelling, because there is edema. So the hallmark is stormy sunset sign for venous occlusion, and pale retina, narrowed vessels for arterial occlusion. If it is a branch retinal vein occlusion, the same stormy sunset will be one part of the retina, but if it is a central retinal vein occlusion, the hemorrhages will be all over your ophthalmoscope. Here you have to give anti-VEGF for macular edema, laser neovascularization or photocoagulation. These are the therapies, but these are ocular emergencies where main thing you have to refer to an ophthalmologist for a proper management. Other than that, the other high topic is retinitis pigmentosa, where the history may come like this. A 24-year-old young gentleman with a family history of retinitis pigmentosa is reviewed in the ophthalmology clinic. He reports worsening of vision over a few months, so gradual onset of loss of vision. And what will be your fundoscopic finding, which is most important to diagnose as retinitis pigmentosa? So if the clinical feature shows like this, bony spicules, then it is probably more pathognomonic. So night blindness and progressive tunnel vision. So periphery of the vision is getting affected. So ultimately central vision will be protected in a person who has a family history. So peripheral retinal degeneration is occurring. So what is happening when in night vision, low light pupil is dilated, then the night vision is more affected. So night blindness, progressive tunnel vision is pathognomonic of retinitis pigmentosa. So again repeating, in a young gentleman with family history, night blindness with progressive tunnel vision is a pathognomonic sign of retinitis pigmentosa. So what will be the fundoscopic findings, because they will give the fundoscopic finding for a pathognomonic feature like bony spicules shaped deposit in the peripheral retina, and mottling pattern appearances, and progressive attenuation of the retinal blood vessels, not a rapid narrow down, not a hemorrhages. So ruling out vascular pathology, which occurs more in suddenly rather than a progressive loss of vision. So night blindness and tunnel vision are pathognomonic, with bony spicules in the fundoscopic finding is featuring retinitis pigmentosa, which is a progressive loss of vision over few weeks or months. Then other thing is like posterior vitreous detachment, which usually the history will give off flashes of light, flashes and floaters. So a 71-year-old type 2 diabetes, hypertensive, having a sensation of light flashes in the right eye. Symptoms have been there for last 2 days, so relatively progressive, more in the peripheral part of the vision. So a progressive thing is going on in a vasculopath with features of light flashes. So here the diagnosis is vitreous detachment. So what happens when there is a vitreous detachment? The light falls before where it should be. So ultimately the vision is affected. So floaters and flashes will be there. So light flashes will be bright light shining. Flashes, floaters will be something floating in the vision. So these are features of vitreous detachment. And if you do a optical coherence tomography, that will confirm the vitreous detachment from the posterior part of the eye lobe. That is a confirmatory test, the OCT. The differentials are retinal detachment and vitreous hemorrhage. So if somebody says about flashes of light, it will be only vitreous detachment. If there is a dense shadow that starts peripherally and progresses towards the central vision, is retinal detachment. There is no flashes in here. In vitreous hemorrhage, there will be sudden visual loss, not a progressive one. So for a management in a physician's clinic is very simple. You just refer to ophthalmologist, but otherwise for vitreous hemorrhage, retinal detachment, these are basically ophthalmic emergencies. So patient has to be controlled in terms of the comorbidities and warned about the dangerous signs so that he can refer to ophthalmologist as quickly as possible. Another topic is glaucoma. Two types. One is the open angle glaucoma and is the angle closure glaucoma. So in open angle glaucoma specifically, there is no obstruction. So it is a problem with the flow. So the question is, what is the risk factors for primary open angle glaucoma like diabetes, family history, hypertension, Afro-Caribbean ethnicity, or hypermetropia? So if you think hypermetropia is a risk factors, so it is a risk factor for acute angle closure glaucoma, not for open angle glaucoma, where flow is disturbed but not occluded. Both the features, there will be rise in the intraocular pressure, and ultimately it will be causing problem on the optic disc, causing swelling, and the optic cup will be more in the diameter. So in open angle glaucoma, it is functionally obstructed. So hypermetropia is not a risk factor. It more occurs in myopic hypertensive diabetes with vasculopaths, and it may be higher in population with Afro-Caribbean population, but not in patients with hypermetropia, which is a risk factor for angle closure glaucoma. So what are the pathognomonic features? Peripheral visual field will be affected, tunnel vision will be the thing, and there will be of course a decreased visual acuity. So what happens? The normal cup to disc diameter increases more than 0.3. So basically increased pressure, intra-ophthalmic pressure increases, and that causes pressure on the optic disc, so it ultimately gets dilated. Other fundus findings are notching and bayoneting of the blood vessels because the optic cup is increasing in size. But mostly it can be diagnosed with the measurement of the intraocular pressure and split lamp examinations with detailed examination of the optic nerve and fundus assessment.